Good morning, PT on Ice crew. My name is Dr. Britt Lademann. I am talking to y'all from Portland, Oregon. And today we're going to talk about, that patient that we often see in the outpatient clinic who's got low back pain and hip pain, both presenting together. And what we really want to hone in on is, as we zoom out through the lifespan, and we look at the prevalence of two fairly common conditions for the musculoskeletal system, which is hip arthritis and spine arthritis. These things often present together. We often treat them together, and they both impact function and movement. Certainly pain and those pain areas can overlap quite a bit. So in that older adult patient who is presenting to you with both problems, and they've been going on for quite some time, and maybe they've already come to you and certainly got that screening spine x-ray that has degenerative discs and arthritis and all that fun stuff, and hip arthritis. And now classic hip arthritis, like any arthritis, tends to be unilateral, or at least there is a side that is more pain dominant or more progressive. And oftentimes in the medical system, these patients eventually find themselves getting a hip replacement. And when we look at the outcomes for hip replacements, we see that they're very good. These people do very well long term. Now, we don't see the same outcomes in spine surgeries for arthritis. And I think there's much bigger question marks in orthopedics, certainly, about how much does spine arthritis actually impact spine pain? How much can we say it's causing pain and dysfunction? And certainly what we've seen in the last decade or so is a movement away from fusing all of these arthritic or degenerative spines. And so with the prevalence of aggressive spine surgery kind of dropping, we've seen the rates of hip surgery maintain or increase over time. And there are wildly different outcomes in both of those post-operative situations, right? And so what we see is a lot of patients who have pain in both areas, typically just getting a surgery for the hip. Okay, so hips in general, hip OA is fairly common. Up to 40% of our older adults will have OA in the hip. Almost 75% of patients, of older adults, will have spine arthritis. And of older adults, people over 50 who have hip pain, hip arthritis is like the number one proposed cause of hip pain in that population. So this is quite a large swath of the population. Now, what I know every outpatient clinician knows is this, case example patient could look wildly different, right? We have people that are fairly functional and active, finally getting a hip replacement, and maybe not needing a ton of physical therapy after surgery. And we see these chronic persistent pain situations with the low back and hip pain fields starting to expand. And we sometimes see that those people don't do super well or don't do as well as expected or on the expected timeline after a hip surgery. And it's kind of a no duh statement, but I don't think it's something that we are doing a great job in the medical profession at large of talking to our patients about. Is not every hip surgery is going to have the same post-op journey, right? What I certainly see a lot is patients who, after years of pain and progressive dysfunction, end up getting a hip replacement. Their doctors are hyping them up. They're looking at those great post-op outcomes and they're saying, you're going to crush it. You might not even need PT. Half the time, these patients have maybe already seen me for something else and just feel like they should do PT, but they don't even get a referral for PT. Right. And so, regardless of presentation, what I'm seeing these patients all go through is this: hey, you're going to crush it post op. You might not even need PT. 1 month and you're back to all of your normal daily life, and there's no restrictions. Right. We're moving away from all of these, for good reason, all of these maybe fear avoidant inducing hip post op restrictions. So, I see a lot of patients who have this comorbidity of low back pain and hip pain coming to me 1 month out of hip surgery and saying, "Hey, I feel like crap. What's going on? My doctor said I was supposed to be back to normal by now." So, what's the problem for how common this surgery is, hip surgery? We see wildly different clinical experiences in these patients. Regardless of where the evidence points us, we see a lot of different presentations. So one problem we have is, what do we prioritize when we're treating these patients pre and post op? Spine pain, hip pain. What should our treatment targets be? Knowing that one of those things we're going to get a surgical intervention for. And maybe even more importantly, how do we set expectations in our patients as healthcare providers to give them the best post-op outcomes? And then that last little question hanging in the air is, do we even need PT? Do we even need PT after a hip surgery? What about those patients with low back pain? So there's this really nice article that came out in 2022. This is the Journal of Arthroplasty. So a little bit of a different perspective. They took 500 patients, and they all had, between two different surgeons, they all had hip surgeries. 40% of these people had back pain before the surgery. So we had a fairly large pool of patients that had that low back pain plus hip pain. And the research article was like, hey, does low back pain improve following total hip arthroplasty? So that was the title of the article, 2022 Journal of Arthroplasty. We will include the link for y'all to look at if you want to. But it's a cool question. It's a good question, right? So I think coming from a PT mindset, not even certainly an orthosurgeon mindset, if we're thinking about like what's the bigger rock in the jar, if we have a dysfunctional hip, we could totally see that relationship between dysfunctional hip over time causing back pain. If we fix the primary cause, are we going to fix the back pain too? And if the hip dysfunction is truly what's driving the back pain, then perhaps we could see a really good improvement with a hip surgery, right? And so the outcomes that they measured in the study were ODI, and they also took a little bit of data. One data point, which I actually had to look up because it's not a phrase I was super familiar with, was pelvic incidence, which is the measurement of kind of, you take the base of the sacrum and including kind of the relative tilt of it, and it's just the spatial relationship between that and the head of the femur. So this is a innate anatomical alignment measure that does not change functionally. So we have a lumbopelvic, we could say, postural measurement. That was taken pre and post-op, not really expecting a change there. And then there was sacral slope, which is a measurement of that pelvic tilt. And so they took some data on how much movement does the spine have? This is pre and post-op. How much movement does a spine have in a sit to stand? So they're measuring that pelvic tilt pre and post-op. And then they followed up with these patients 1 and 2 years after their hip surgery. Okay, so on the question of does low back pain improve following total hip arthroplasty, the results were fairly strong for yes. So what they saw was 1 to 2 year follow-up. About 80 to 90% of the patients who had low back pain pre-surgery saw resolution of their low back pain. That's huge. That wasn't just statistically significant, clinically significant difference in low back pain. At that 2 year mark, 80%, 90% of those patients with low back pain after hip surgery had resolution of their low back pain. Very cool. Very interesting, right? Interesting for those of us that like to think about that whole biomechanical system and how it all must be playing together, right? So they could have measured a bunch of other stuff here, like expectations, but what they did measure, again, were those changes in the pelvic tilt, essentially during a functional movement like a sit to stand. What they saw was the overall anatomical alignment, so the static postural, that pelvic incidence measure, that did not predict success. What predicted success in reduction or resolutions, rather, of the low back pain was whether or not the spine moved more than 10 degrees, so that sacral slope change of greater than 10 degrees during a sit to stand. The patients that had movement in their movement potential and actual movement in their lumbopelvic system during a sit to stand were the ones that had resolution of back pain at that 1 to 2 year mark. Really interesting, especially because when we're thinking about these patients, in traditional physical therapy, what are a lot of our low back pain, lumbopelvic, plus a little bit of hip pain patients getting from their physical therapists? We tend to throw a lot of core stability at these patients, and certainly there's a place for it, right? Like strengthening and core stability, but it seemed to be the ability of the spine to actually move that predicted success in these patients in this study. So it's all kind of interesting, but I think the takeaways for us is one, that patient, that case example of I've got low back pain and hip pain, I'm not sure which area to focus on the most. At least surgically, we can very strongly say that there's a fair chance at 1 to 2 years, we're going to see a significant improvement in our patient's low back pain after they address a problematic hip OA situation. Now, so on our questions of what should we prioritize in this patient pre and post-op, what do we know is going to change post-op? The mobility of the hip joint is going to wildly improve, right? We're going to see better range of motion, certainly at least better passive range of motion measurements post-op. Now, whether or not they have better active range of motion speaks a lot more to their strength through range, which is absolutely something that PT is fantastic at developing, right? So thinking about how do I get this person the most successful post-op with spine and hip pain with a hip surgery, let's get the hips very strong and let's get the back very strong, regardless of our, mobility in either region. We know that big muscle group strength correlates with better long-term outcomes after any orthopedic surgery, including hip and spine surgery. Do we hammer hip mobility aggressively before a hip replacement surgery? If stretching or mobility work helps the patient feel better or improve some movement, I think sure we can make a case for it. But pre-op, let's just get that person as conditioned and as strong as possible. Now, post-op, I guess the last little question there is, what do we do with the spine? Are we doing basic core stability work? Are we doing back strengthening? I think yes. And then maybe extrapolating a little bit from this research article, perhaps it's mobility, functional mobility in the spine itself that is a prerequisite for success. And so while we might not hammer down hip mobility pre-op in these patients, we might try to begin that journey of improving spine mobility. Now, how long does it take to truly change the mobility of the lower lumbar? It takes a long time, but it also speaks to a lot of habits and lifestyle interventions that we might need to make with that patient. Okay, so that's the order of priorities, which is, as much of an art form as a science. How do we set expectations with these patients? Again, my personal experience in the clinic is a lot of high expectations from the ortho team. And I would say 50% chance or more that those patients that I then treat in PT are disappointed that they're not 100% in, 1 month or 6 weeks. And so I will always set expectations with my patients based on the patient in front of me, right? Again, that highly active individual, we're going to be at 6 weeks feeling like we're plugged back into most of the aspects of our life. Someone who has waited years to even address, let alone begin to rehab or, set a game plan for their progressive loss of function, that can happen with a really spicy hip that can then impact the back. Now I'm not even walking a half block because it hurts, and I used to be able to go on 2-mile walks. I can't bend over and lift up the laundry basket. It's been 5-6 years since I've been able to do that comfortably. That's a different patient than my patient who's playing tennis and going on 8-mile hikes, right? So the deconditioned patient, we need to start PT now and we're going to be doing PT for a much longer time span than what often the ortho teams are saying. And so in those patients, we treat it holistically, and we're frank with them, like, hey, we're going to fix this orthopedic, this biomechanical problem. But all of the changes over the last several years, we're going to have to address functionally. And I might not need to see you once a week for a year, right? So our rehab often looks like guidance in that first 1 to 2 month period, maybe 3 month period with PT, and then check-ins over up to 2 years to make sure that they're progressing back to all of these functional goals that it's been, often years and years since they've been able to even consider. So even just looking at this article, right, 1 to 2 years when they checked in on that low back pain, I'm setting those expectations in the clinic of, hey, we're going to see this long-term improvement. And I'm going to be there for you during that journey, but you're not going to need to be in my clinic consistently that whole time. And so that last question of, do we need PT? I think we do need PT for that spine pain plus hip pain patient, but we know that long-term, those patients are going to do really well. So we don't need to do tons of PT post-op for months and months and months. We need to make sure that they have the motivation and the tools to achieve their goals. And we need to be resources for these patients over that 1 to 2 year period so that they can check in, retest their glute max strength, make sure that they're progressing on their walking program, all the things that they need to do to stay motivated and to stay in the game for that long run. That's where I think we really make the case for PT in these patients with back pain and hip replacement. So last thing, if you have this patient who's waffling on a surgery for the hip, we know we have really strong outcomes. We know they're going to do really well in the long term. It goes a long way to be frank with them, setting expectations that, yes, on paper and on Google, this is a 1 to 2 month rehab period that may or may not need PT. And you have that frank conversation with them about, what are your goals? Do they seem realistic given your current conditioning level or not? And if they don't seem realistic given that person's current conditioning level, that's where PT can be a fantastic resource. And maybe it is just every 2 months checking in with someone, making sure they're hooked up with the personal trainer, making sure they're comfortable using the gym equipment that they have access to, whatever that might be, that gets to be tailored to the individual in front of us. So out in the clinics, encourage those patients getting hip replacements. They are going to have great long-term outcomes. Oftentimes, we're fixing a lot of back pain problems as well. And it might be more important to address that functional spine mobility and then spine and hip strength together in the clinic, both pre and post-op. All right, y'all, that's it. Again, I'll share the link to this article if you want to dive in and just look at that anymore. Have a lovely week, and thanks for the listen.